Hi, this is Dr. Desmond White, gastroenterologist. Today I want to share one patient that I did a PEG feeding tube for dementia. Okay, so we call him Mr. A. Mr. A is an 80-year-old man. I saw him once. I saw the son first actually. For people that have dementia, it takes a lot of effort to bring them to a hospital or to see a doctor. So usually the son will come, or the daughter will come, we talk. If needed, we just use a Zoom call or use a WhatsApp video call. I can eyeball the patient, etc. And it's also very important for me as a gastroenterologist to work with the home care doctor. Most demented patients that need medical care, they see a home care doctor. They will visit the home on a regular basis to provide medical care like diabetes, hypertension, etc., etc. So this gentleman, Mr. A, was 80 years old. He had dementia. He had been bedbound for many years. He had no bed sore. The son take very good care of him. The helper take very good care of him. The son is super meticulous. I wish every son can take care of the parent like the way Mr. A's son took care of him. Anyway, so the problem for him is that they have this repeated nasogastric tube, that the tube blocks on a very frequent basis, so the doctor have to change the tube. And it's very painful and inconvenient to change the tube. In US, they actually prefer to do a PEG tube because if we have to change the tube, sometimes they have to bring a demented patient from home all the way to the hospital just to change the tube. And if you go to the hospital, you take a cab, you take a Grab, you take MRT to see a doctor, or it's called ambulance. For a demented person to go to a hospital, you really need to have some form of transport, and it is expensive, it is very messy. You may need a few people to come and carry him from the bed to a trolley, transfer by a trolley, then the ambulance or the transfer wait for the patient. After the consult, bring the patient back home. So a lot of effort, a lot of money. So the son came first, so we spoke. I told him the option of continuing nasogastric feeding or putting the percutaneous endoscopic gastrostomy tube feeding, or PEG or PEG tube feeding. So the good thing of PEG over the nasogastric tube, I told him like that, is that it's bigger bowl, it doesn't go to the nose, it can feed more stuff, it can feed more viscous stuff like porridge or like porridge. It can feed medication without fearing that it will block it. It doesn't go to the nose, so it doesn't cause so much discomfort. It doesn't block the sinuses drainage, so it doesn't cause this sinusitis. It doesn't cause esophagitis. And because the gap between the esophagus and the stomach are close, it is more healthy, more physiological. And we can feed a lot of stuff without fearing that it will block. And it doesn't need a change for maybe a year to two. So there are many advantages. But as in anything in life, there's always up and down, pros and cons. The cons of a PEG tube is that patient has to go for a procedure. So I told him I need him to be in the hospital. I would give him some antibiotics to reduce risk of infection. I put in the scope with a colleague. Usually I do the top and someone do the bottom. I will put the scope from the mouth under the esophagus to the stomach. I shine light, so my surgical colleague, in that case, was Dr. Ganesh. Dr. Ganesh is a friend and colleague, and he was helping me. So Dr. Ganesh looked for the light outside on the surface of the abdominal wall. He said, hey, that's the stomach. So if that's the abdominal wall, my scope is inside. I shine light, and from the outside, through the stomach wall, abdominal wall, Ganesh see the light. He knows where the stomach is, so we won't miss, okay? We won't be poking into the colon or other organ. So he put in the needle above into the stomach. I would have a little gadget to pull this wire up, and then we establish a connection from outside through the wire, through the skin, through the stomach wall, into the stomach, and come up from the mouth. I will then thread a feeding tube inside and pull out from here. The whole process takes about 10-15 minutes. We secured the PEG, it was well done. And after that, patient sent back to the ward. I told the patient we'll start feeding the tube with just water for the overnight. I never rush patients to go back because as a doctor, I'm very worried that I will cause complication like bleeding, perforation, or peritonitis infection. So after that, patient go back to the ward, we start feeding water. If they're fine, no issue, that's great, okay? Then we can start feeding the next day. And then at that time, I remember asking a dietitian to come in. They have a formula to calculate how old you are, your activity, how much calorie you need. We then choose a good feed. There are a few different brands: Ensure, Isocal, the different brand. There are the pros and the cons depend on the patient condition, depends on whether patient have allergy, depend on patient have diabetes, etc. So we calculate how much they need. Then after that, we start feeding in the ward. That patient, I told the patient, please don't rush home. Let us make sure the feeding is okay. Make sure your helper is comfortable in feeding, because they may comfortable feeding nasogastric tube. When you go to the PG tube, the feeding similar but slightly different. So the helper must be comfortable. We will divide, we calculate how much calorie they need. We depend on how much feed, what kind of feed they need. We calculate how much in quantity. We divide into 4 to 6 aliquot and we feed them. And I told the patient, after you feed through the PG tube, there's a dead space in the PG. You must flush with about 20 to 50 ml of plain water to flush it down. You don't want the milk or the feed to coat the inner lining of the feeding tube. So after that, after we do that, then after 2-3 days, when the helper is comfortable, feeding amount is fine, no complication, we touch belly, no fever, no pain, patient pass motion, then the patient go home. And then I work with my colleague, in this case is Dr. Lau. Dr. Lau is a home care doctor. He will see the patient, he will take video, take photo of the patient, WhatsApp to me. I can even see what's happening. So I don't like to go to the patient home because my clinic quite busy, okay? And home care doctor, they have all the gadgets, they know what to do. If I go there, something happen, I don't know what to do. So the home care doctor, in this case, Dr. Lau Chun Hong, Dr. Lau went there and then make sure everything is okay, and see him a couple of times until happy patient take over. So that's how we put in PG. The PG tube, under the manufacturer advice, they say that we should change the tube every year. And that's because after a while, the tube become more and more brittle. And sometimes the inner side become moldy, sometimes it block, okay? So we change a new tube. I think after about a year plus, Mr. A's son brought him back. We changed a new tube and they was doing very well. And Mr. A's son told me that the father did very well. With the PG tube, they can feed more. They can feed more medication. The nose are much less uncomfortable. Patient put on weight with no bad sore. So that was a very, very good outcome. So I did remember telling Mr. A's son that there's risk of perforation, risk of bleeding, risk of infection, risk of pneumonia, and the procedure can fail. But I think Mr. A's son take care of all the complications, and we proceeded, and I'm grateful for his trust, and I'm happy that Mr. A is doing very well. Looking back, there are other ways to feed him. We can continue to feed him through the nasogastric tube, but there are those problems I mentioned: sinusitis, small tube dislodgement, tube blockage. Some people have tried to put in the PG tube without a scope but through radiology. So if this is stomach below, muscle on top, they under x-ray see where the stomach, put the needle in and put in the feeding tube. I haven't done that for myself, for my patients. According to medical study that I read, there's no head-to-head trial comparing the two techniques. Most studies show that they are safe. The risk of serious complication is very, very low. So this is a happy case, but it's not easy. For Mr. A's case, it's easier for me because he had 2 sons. One son called the shots, so the son make all the decisions. That's easy. Some patients, they have many children. Some patients say, don't take any risk. Okay, even if the risk is 0.1%, I don't want to take. And but then this tube is causing problems. Sometimes we see relative children, even though everybody wants to do the best for the father or the mother, they end up quarreling in front of me. Okay, so the decision making is important. They must be able to take the risk. If he's successful, it is a much, much better option than the nasogastric tube. So I share some of my patient story. I hope it can help you decide for your loved ones if your loved one need to have a PG tube insertion. This is Dr. Desmond White, gastroenterologist. Thank you.